This event is basically going to talk about systemic sclerosis. So, I'm the one who started the event, as I said. I will then pass the microphone to Dr. Mohammed Akil, who has supported us a lot in the recent years to do this type of work. He's consultant rheumatology at ASTH at the Sheffield Hospitals Trust, and he will make an introduction on systemic sclerosis and also speak about recent therapeutic advancements. Then we will have our study participants to talk about their experience, whether they enjoyed it or not, the good things and the bad things. So we're going to play a short video, but we prepared for that. Following that, we have one of our international collaborators, Dr. Karina Bonstrom from Sweden, who is going to speak about how it is to work in a multi-center trial and whether it is easy for us to make it work. And this is a key element of the thing that we're doing, because as you can imagine, systemic sclerosis and other conditions like that are considered as rare. So it's not easy to find people, all the people in need in a specific place. So therefore, you need to collaborate with other colleagues, other researchers all over Europe, all over the world, as a matter of fact. Then we're going to listen to Alexandros Mitropoulos. You know him probably. Most of you know him already, who was the driving force behind this study. And he will speak about how and what did we find out, and quite important, what can we do next. And at the end, as I said at the beginning, we'll have some question and answer time to the team. So keep your questions, and we would like those questions actually to be asked. So don't be shy. All right? So Mohammed, it's over to you.
So thank you again. Can you hear me okay? Yes. Great. So I'm going to talk about systemic sclerosis or scleroderma, just about the condition and talk about treatment. So is it systemic sclerosis or is it scleroderma? So we need to explain the difference. Do you know what scleroderma means, where it comes from? So it's Greek. So sclero means scleros in Greek is tough or hard, and derma is skin. So it's a tough or hard skin. Is that correct? Yeah. Excellent. So scleroderma is an umbrella term for several conditions that can be similar, of which systemic sclerosis is the commonest. So the other conditions include morphea, which is a condition similar to scleroderma, but only affects the skin. It does not affect the internal organs, doesn't affect the blood vessels. And this can be linear, as in it comes in lines, or it can be all over the body, what we call generalized morphea. And there are similar conditions called eosinophilic fasciitis and foot overlap syndrome, other connective tissue diseases and autoimmune conditions that can cause features of systemic sclerosis. So I'm going to focus mainly on systemic sclerosis. So what is systemic sclerosis? It is an autoimmune condition that affects the skin and the connective tissue. So what happens in autoimmune conditions is that our own immune system, which is there to protect us against infection and against cancer, can turn against us. That means the body attacks its own healthy tissue. And that can cause inflammation, that can lead to scarring, hardening of the skin, and other features. And systemic sclerosis has got a spectrum, a range from the very mild to the very severe. It can even be life-threatening in some cases. So what happens in the body in systemic sclerosis? Three main things. One is you get some vascular abnormality, or what's called vasculopathy. And Raynaud's is one of the commonest symptoms where you get abnormality in the blood vessels. But these things can happen in other organs, can happen in the lungs, can happen in the heart and the kidneys. The other pathology or abnormality is you get excessive collagen deposition. So that means it lays a lot of scar tissue in the skin, and that's what causes the skin to harden. But you can see the similar changes in other organs. And the third thing that happens is inflammation. So there are subtypes or different types of systemic sclerosis. By far the commonest is the limited cutaneous systemic sclerosis, and that used to be called the CREST syndrome. We don't call it CREST anymore. And this is the more benign form of systemic sclerosis. The second, which is rarer, is called diffuse cutaneous. That means the skin affected all over the body, and this is potentially a more serious form where the internal organs are affected more commonly. Sometimes we see patients where they have all the internal organs affected, but not the skin. And we call this systemic sclerosis sine, as Latin means without scleroderma. So it can have lung and heart involvement, but the skin is not involved. And the overlap syndromes is where you get scleroderma features associated with other conditions like lupus or rheumatoid or other autoimmune conditions. And there's a condition that's called mixed connective tissue disease, which has some features of scleroderma as well as lupus. So just to explain the two main subtypes of systemic sclerosis. So on your left there is the limited disease. The limited disease means the skin involvement, usually limited to the fingers and toes. The face can be affected. This can be extremely mild in some people where the skin involvement can be really, really minimal, and it can be more severe. In the diffuse type, the whole body is affected. So the chest, the arms, the legs, everywhere. And there are differences. So in the limited type, patients usually have Raynaud's for years before they develop the limited form. In the diffuse type, the skin changes and the Raynaud's come around the same time, or certainly within a year. So they're two very, very different diseases. As we said, the skin changes is limited to the hands and feet and face. In the limited type, it's all over the body in the diffuse type. In the limited type, the main serious complication is pulmonary arterial hypertension. And that is a late complication that usually happens after years and years of Raynaud's and skin changes. Luckily, that only happens in about 10% of people. So 90% of people with limited disease will not have pulmonary hypertension. Other late complications include digital ulcers and the fingers, calcinosis, and telangiectasia, and I'll explain about this a bit more. In the diffuse disease, the complications happen early, usually within the first 3 years. So people that are going to have problems usually happens, in 3 to 5 years. If nothing happens within 5 years, then it means it's probably things will settle and they're less likely to get problems. Antibodies. So these are blood tests that can tell us which form the person is going to have. So if we see a new person with Raynaud's and new signs, and we know that they've got a positive anti-centromere antibody, so just a blood test, we know for sure that this person is not going to have a diffuse disease. So the risk of having heart and lung and bowel involvements are much, much less. And if the test positive for anti-SCL70 or anti-scleroderma 70 or another antibody called RNA polymerase 3 antibody, that means there are a much higher risk of developing the diffuse disease. So this is a typical Raynaud's. So classical Raynaud's goes in 3 phases. The first phase is the vasospasm, in the blood vessels go into spasm, so you don't get blood going through to the fingers or the toes or the nose. So they turn white. After a short while, you get lack of oxygen into the digits, so the fingers will turn blue. And in the third phase, when the blood vessels eventually relax, you get excess blood going through and they turn red. So the classical Raynaud's goes white, blue, and then red. But that doesn't happen in everyone. Some people go straight from white to red, sometimes white to normal. In the early stages of systemic sclerosis, you get this reversibility. So the blood vessels are normal. They're just very sensitive to change in weather. But after years of disease, you start to get damage within the vessels. So you don't get So it gets more severe, and they start to get a blockage in the blood vessels, and that can lead to ulcers. Just to mention that Raynaud's can be caused by other conditions other than systemic sclerosis. By far the commonest is primary Raynaud's. Primary means there's no underlying problem. It's usually mild, almost always starts in late teens, early 20s. Raynaud's that starts later on in life is always secondary to other conditions. So we do see Raynaud's in other autoimmune connective tissue diseases, including lupus and myositis, not just in systemic sclerosis. But you can see there are lots of other causes for Raynaud's. Some vascular causes like furring of the arteries, and neurological problems, drugs, vibration injuries, what we call vibration white fingers. And lots of drugs can cause and aggravate Raynaud's. So this is capillaroscopy. So these are the tiny blood vessels that surround the fingernails. These vessels are not visible to the naked eye, but if you use a magnifying lens or a microscope, you can see. So on the top left there, you can see the normal blood vessels. So they're tiny capillaries. There's plenty of them. They have a hairpin shape. That's what is normal. In systemic sclerosis and other connective tissue disease, we start to see some changes there very early on, and that can help us to make early diagnosis of systemic sclerosis. So here you can start to see some bleeding, some hemorrhages, start to see some bigger blood vessels, and there's less of them. In the active phase, you see more hemorrhages and far less vessels. And then later on, what you see here, you lose the normal organized pattern, and what you see is completely disorganized blood vessels where they're trying to regenerate. So this is something we can do in clinic early on in the disease to see people that have primary Raynaud's will have normal blood vessels. So the skin involvement, said the main involvement is the skin thickening, and that can be very variable from very mild to very severe. But patients with systemic sclerosis can get other skin symptoms, including itching, which can be very, very severe in the early stages of the diffuse disease. They can get swelling or edema. They can lose pigments or have extra pigments, and sometimes you can have what's called a salt and pepper appearance. Can cause hair loss, ulcers in the fingertips, and then pitting. And I'll show you what telangiectasia calcinosis look like. So telangiectasia is these tiny red dots caused by dilatation of the capillaries. And if you press on them, they disappear. And then if you take the pressure, they fill back. And you can see these on the fingers, you can see them on the face, even on the tongue and mucosa. And they can be present throughout the GI system and the respiratory system, and they sometimes can bleed. This is called calcinosis, where you get calcium deposits under the skin that sometimes can ulcerate and get infected and bleed. And these are pits in the fingertips from ulcers. What happens in the gastrointestinal system? Several things. The first three are common in both types. So you get esophageal dysmotility. The gullet, which is a muscle, it loses its function and it starts to get disorganized movements, which can cause difficulty swallowing. And you start to get reflux. It should have a valve at the end to stop food coming from the stomach back up. And when you lose that, you start to get indigestion and heartburn. And that can lead then to scarring, which causes strictures, which can cause difficulty swallowing. In people that have diffuse disease, you can get similar changes in the bowels. So they get scarring in the bowels, so you get bacteria growing, which shouldn't grow, which can lead to diarrhea, malabsorption, and weight loss. We don't see that in the limited type. Heart and lung, you can get lung fibrosis. It's rare in the limited type, it's quite common in the diffuse type. Myocarditis, which means inflammation in the heart muscle, which can lead to heart failure and can lead to abnormal rhythm. And pericarditis is inflammation in the lining of the heart. And again, these two are seen mainly in the diffuse disease, not in the limited disease. The pulmonary hypertension, which is a complication that we see in both types, but only in 10%. Other complications include inflammatory arthritis, particularly in the diffuse type, where you get joint inflammation and swelling, particularly in the hands that cause poor grip and stiffness. Can get muscle inflammation or myositis, which can lead to muscle weakness. And then renal crisis, so I mean acute kidney failure, and that called a crisis because it happens very acutely. And what happens is patients will have sky-high blood pressure and they go into kidney failure. And this is a complication of people with diffuse disease that carry the antibody that's called RNA polymerase antibody. If this is treated early, it's completely reversible. Unfortunately, if it's detected late, it can lead to kidney failure and the need for dialysis. So it's sadly, we still see patients presenting with renal crisis with have undiagnosed systemic sclerosis, which is something we should try and avoid. Sjögren syndrome is very common in both types, and that causes dry eyes and dry mouth. We see Sjögren in lupus and other types of connective tissue disease. So moving on to the management, how do we manage systemic sclerosis? The number one is really make the diagnosis early, because any delay in making the diagnosis means we're risking significant complications which can be avoided if detected early and treated early. Ideally, patients with systemic sclerosis should be reviewed in specialist clinic, in clinics where the rheumatologists are familiar with systemic sclerosis. It's really important to empower the patient. Education, lifestyle changes, of which exercise is very important. We're going to talk about that later. And for a lot of patients, we don't really do much in the way of treatment, but the main job is to screen for major organ involvement. So all patients, particularly of both types, should have annual heart scans and breathing tests, and to pick up changes in the heart and lungs very early. And then the appropriate drug therapy. So going back to what happens in the body and see for each abnormality needs different treatment. So for the vascular abnormality, we need to use vasodilators. So vaso means blood vessels and dilators, medicine that dilate the blood vessels. So we use vasodilators to treat Raynaud's, to treat pulmonary hypertension. The excessive collagen deposition is a new group of drugs called antifibrotics. And we have one antifibrotic drug that we use in lung fibrosis and scleroderma. Unfortunately, we don't have an antifibrotic for the skin just yet, but I'm sure it will come. And then we treat inflammation by immunosuppressive drugs, because what causes the inflammation is the overactivity in the immune system. So now going back to just general management of systemic sclerosis. So the first thing is the treatment of Raynaud's. So before we get onto drugs and vasodilators, lifestyle measures are really important. They're simple, they're side effect free. So keeping warm is the number one advice. Not just wearing gloves, but keeping the whole body warm. I'm sure you know more than I do, is you just need to wrap up, wear gloves and warm footwear in the cold weather, and consider using hand warming devices. Now some can get really good gloves. I get really cold hands. I don't have Raynaud's, but I get freezing hands. And I've managed to buy some gloves with heated batteries that are amazing. Avoiding sudden temperature changes. So going to the supermarket in the fridge, freezer section can trigger Raynaud's. And what is really important is smoking. Smoking is really, really bad. So avoiding or stopping smoking is an important thing. Minimizing stress, because stress can trigger Raynaud's, and that's easier said than done. And exercising regularly. So we do know exercise is good for circulation, and I'm looking forward to hearing more about that with your experience later. In terms of drugs, what do we use? Our first line drug is nifedipine. It's a blood pressure tablet. works well, but often causes side effects, causes headaches, ankle swelling, dizziness. Some people can't tolerate it. Our second line drug is sildenafil, otherwise known as Viagra, which again can help Raynaud's, but some people can't tolerate it. Intravenous iloprost to treat severe Raynaud's and ulcers. That requires people to come into hospital, usually for 5 days, get attached to a drip. And we use that during the winter months, and that treatment can last for 3-4 months, but unfortunately it doesn't work for everyone. Fluoxetine is an antidepressant. One of the side effects of fluoxetine, it can open up the blood vessels. So it's worth a try. When you get digital ulcers, then people need to be admitted for intravenous iloprost. We use sildenafil. Bosentan is a drug that can be useful in the prevention of recurrence of digital ulcers. So we try and heal the ulcers first with iloprost and then use bosentan. Surgery can be an option. If you've got an ulcer that needs debriding, or there's an operation that we used to do more in the past called digital sympathectomy. Basically means we cut the sympathetic nerve that supply the arteries in the hand, which relaxes the blood vessels. Botox injections, again, it's something that we have tried in the past, and we're trying to establish again in Sheffield. There's evidence that can help. The gastrointestinal symptoms, all patients should be on an anti-reflux treatment. And that could be with a PPI, which is a proton pump inhibitor, drugs like omeprazole or lansoprazole or esomeprazole. And it's really, really important. If you have reflux, that has to be treated, because recurrent reflux can lead to permanent damage in the gullet and scarring. Sometimes we can use H2 blockers like famotidine, antacids like Gaviscon. The other antibiotics is for diffuse disease where you get bacterial overgrowth. Sometimes there are other drugs that can help with the motility disturbance like domperidone. And in very, very severe cases where you get malabsorption, some patients need to be fed either through the gut or through intravenous line. What about the skin? In the limited disease, we do not treat the skin. It's rarely severe enough to cause problems. But in the severe, in the diffuse disease, it always needs treatment, and the treatment is with immunosuppressive drug. Our first-line drug is mycophenolate. It's a tablet immunosuppressive drug that works well for most people. Methotrexate is another drug. Sometimes we use low-dose steroids. High-dose steroids in diffuse disease can predispose to kidney problems, so we try and avoid it. And ASCT is stem cell transplant. It's something that is available and funded for severe diffuse systemic sclerosis. I can talk about that in a bit as well. So the renal crisis, the treatment is with a blood pressure group medication called ACE inhibitors, ramipril, captopril, lisinopril, drugs that end with a pril. If they're used early, they can prevent progression into kidney failure. The lung fibrosis or interstitial lung disease, we again all require immunosuppressive drugs. Cyclophosphamide, which is one of the most potent immunosuppressive drugs we have, is used intravenously once a month. Also use mycophenolate and azathioprine, which are another immunosuppressive drug. The antifibrotic called nintedanib, which has been recently approved. So this can be used in combination with the immunosuppressive drugs and also the stem cell transplant. The complication that we talked about, which is the pulmonary hypertension, in the UK, you have to be referred to one of a few centres. And I'll show you the centres in the UK. So there are 4 in London. There's 1 in Cambridge. And then in the north, you've got Glasgow and Newcastle. And in the middle is Sheffield. So if you live in Birmingham, Liverpool, Manchester, Lincoln, anywhere north of Cambridge, south of Newcastle, you come to Sheffield, to the Royal Hallamshire. So we have, it's the largest European centre for pulmonary hypertension. So that's good news for people that live in Sheffield, should they need it. So stem cell transplant is something that is used routinely for people with blood type cancer like lymphoma and leukemia, but also it plays an important role in autoimmune conditions. And this is an article about using it in multiple sclerosis. It can be used to treat inflammatory bowel disease, and it is a recognized and funded treatment for severe systemic sclerosis. It's used an awful lot more in Europe and in the States, and Sheffield is the main UK centre for stem cell transplant. So we get referrals from all over the country. And when we talk about stem cell, this is the hemopoietic stem cell. So this is the blood stem cell rather than the embryonic stem cell. So if you look on your right there, these are all types of blood cells. So you've got the white cells, the platelets, and the red cells all come from one cell, which is the blood stem cell. So this is quite a drastic treatment. So with immunosuppressive drugs, we're trying to kill a few of the cells. We can't kill them all, just enough to suppress the disease. Here, we want to kill the whole lot. And this is autologous, means we don't need donors. We use the patient's own stem cells. So it goes into phases. The first phase is to collect and harvest the patient's stem cell. So patients have a dose of chemotherapy of cyclophosphamide, and then the stem cells are collected. I'll show you how they're collected. And then they're frozen. They're stored and frozen. The second phase is to admit the patient for intensive chemotherapy. They have massive doses of cyclophosphamide to kill all their immune cells. And then they get the stem cells that have been frozen, they're defrosted and reinfused back into the patient. So what that does, it reboots the immune system. So it's your own cells, so you're not going to have rejection, but it will, in the hope that it will improve the inflammation, and the next lot of cells that are being regenerated are not as autoreactive. So on the left, you see this, what's called an apheresis machine. So this is one of our patients who underwent stem cell transplant, attached to a machine that goes into the vein, and they circulate into the machine and collect all the stem cells. And then the second phase, they need admission for 3 to 4 weeks. During that period, you have no immune system at all. So the person is extremely vulnerable. So they isolated in a special room, and they need a lot of supportive treatment, and they can be pretty sick. After 7 to 10 days, the bone marrow start to regenerate, and you get a new immune system. But what happens then? All your memory cells, all your childhood vaccination is all gone. You need to revaccinate again because you have a completely naive immune system. Hopefully, it will be less reactive. Now, this is shown to be very effective in people with severe systemic sclerosis, but it's a very risky treatment. There's a very high treatment-related mortality. So in the largest study in Europe, the treatment-related mortality was 10%. So that's 1 in 10 people that didn't survive it. So if you select patients carefully, you can reduce that to about 4 to 5%. So this is not treatment for everyone. It's something that is available for people that have very, very serious, very aggressive diffuse disease, where the risk of not treating them is probably worse than accepting that small risk. So this is something that we do in Sheffield, but it's for a very, very small number of people. So the future is, I think, it's promising. Now there's lots of interest in systemic sclerosis. After years and years of nothing happening, now there are at least 12 studies that are currently recruiting nationally for people with systemic sclerosis. We have one study in Sheffield that is up and running and recruiting for diffuse systemic sclerosis, looking at a drug called anifrolumab, which is licensed for SLE, and to see if it helps the skin in people with lupus. we're about to start 2 more studies, one including stem cell transplant. So there is hope. If I was giving this talk 15 years ago, I would say really there's not much we can do, but now I think things are much better. I'm just going to finish with this really exciting new development, and that's a study that we are going to do, something called CAR T-cell therapy. You may or may not have heard of it. So the CAR bit is nothing to do with CARs, it's the chimeric antigen receptor. So in here, instead of using drugs to kill the cells, we use T cells, which is patient's own cells. So what happens here is you collect T cells in a similar way to how we collected the stem cells, and then you send them to a factory where these patient's own T cells are injected with a gene that can then express a receptor on the top, which is designed to kill a certain type of cell. And then these are then allowed to grow in a culture and then reinfused back into the patient. The advantage of this, we're not using drugs, we're using patient's own cells. In this case, we're targeting B cells that are active, and the advantage of this over drugs, that T cells can infiltrate into the tissue and not just causing the problem with so less side effects and more targeted treatment. So CAR T cells is currently, again, available for blood cancers, and there's some very, very promising reports in autoimmune conditions like lupus and scleroderma. And we're in Sheffield, we're going to start a trial of CAR T cell at the end of this year or early next year. So watch that space. It's really interesting. So I'm going to finish here and say thank you for listening. We'll have questions later, and I'm sure you all know about the Scleroderma and Raynaud's UK and provide support to people with scleroderma. Thank you.
Very much. Certainly very exciting news for the future, and obviously we have our own work. We'll talk about it a bit. We will now move to the next speaker. The video.
I'm Janice. I live in Sheffield and I've been diagnosed with systemic sclerosis for the last 6 years. I was always feeling tired. I couldn't explain it to anybody, just like a balloon, and balloon just goes. Now I'm very different. Since I've got on the medication and I've been doing some exercise, it's helped me immensely. I've been able to walk more. I'm doing maybe a couple of miles walking a day. I'm doing heavy housework. I'm making the beds myself, and I don't get help. I do it all on my own. To get back home after the first day, it took me an hour and a half to get home. I was really, shuffling. I thought I'd keep stopping. I thought, this is madness what I'm doing. And then the following time I went and came back and walked it. Didn't take us long. Great. And then I realised I was running down here. I really enjoyed it. After the 3 months, I still continue to exercise the best way I can. It's helped me to socialise now. I can get back to doing what I used to do.
Like dancing?
Dancing, I like dancing, yes.
My name is John. I live in Sheffield, UK, and I was diagnosed with systemic sclerosis less than 2 years ago. I volunteered for your study and straight away enjoyed it. I enjoyed the routine of having to come to Sheffield Hallam University twice a week. It gave me a discipline for regular exercise. So I do a daily exercise with weights now, which I never did before. And I've also joined a gym. and I do swimming, which I really enjoy. But prior to this exercise regime, I would never have considered joining a gym. That was something I didn't think that I would be interested in. Well, the first thing I did was I bought myself some dumbbells so I could replicate the exercises that you'd shown me. So I tried to do those every day, and if I miss a day, there's a feeling of letting myself down. So I'm definitely into a regime, and try to get to the gym twice a week. I make the time now, and I wouldn't have done before. If you just sent me a list of exercises and a set of dumbbells, they probably would have just stayed pretty much unused. But having the one-to-one tuition, it's given me sort of a confidence to replicate them myself. So I can walk into that gym, not feel self-conscious, not feel as though I shouldn't be there. So it's just become a natural thing to do now. I would recommend exercise to everybody, and particularly to try it if they have systemic sclerosis. I can appreciate that for some people that could be quite unpleasant, but for them to certainly give it a try, and they might or hopefully will feel benefits from it.
My name's Sarah, I live in Sheffield, and I've had systemic sclerosis for about 25 years. I don't think I really experience pain and fatigue a great deal. I think I have fairly minor symptoms, but I certainly, due to typical Raynaud's, I turn blue quite a lot, but I don't get pain with it, and I don't think I suffer fatigue. My experience of the exercise intervention was quite positive. I quite like to exercise anyway, and it was a motivation for me to do a bit more. And it was good to do something a little bit different. I can't say I particularly enjoyed hand cycling. I know some of the machines were broken at some of the time when I did rowing, and I found that better, but I did persevere and do hand cycling. I found the hand cycling to be a little bit of a waste of my time, because I only exercised my arms, whereas rowing I could do both my arms and legs at the same time, so it was more efficient for me. Yes, I quite enjoyed the weights. I'm quite feeble, but I found it a good challenge, and I quite enjoyed doing that, and I think I did get a little bit stronger. But it's not my natural place, but yes, I did enjoy it, yeah. I think I prefer the interval training protocol. I'm the kind of person that will probably go for that more than if it's a long duration type approach. I'd be inclined to stop and have a bit of a rest. If I did experience any side effects from the training, I think it was positive. I think I got a bit fitter. I don't think I experienced any negatives. I can't say I noticed it making any difference to my hands going blue. But yeah, I enjoyed there was a positive experience for me. I mean, there's obviously physical benefits beyond just helping with the condition, but I think it just makes you feel better generally. So, those endorphin rushes or whatever they are, they just make you feel better, get out in the fresh air, if you can, in the gym, whatever. I just find it a positive experience.
I'd like to thank you personally for inviting me to do it. I've certainly got a lot out of it, and it's made me look after my body more, and not just exercise by doing walk, but to actually have a daily routine, which if I don't adhere to it, I feel as though I've let myself down. So I'd like to thank you.
I would really recommend exercise to everybody. It's helped me and it will help you.
I met Alexandros at EULAR Congress for more than 5 years ago, and later we started to discuss how to start up an exercise study in systemic sclerosis. And Alexandros, he applied for and received fundings from Forum together with other co-workers. And it was time to start the study. And today I will give some experience and some results from the Swedish patients and the Swedish part of the study. So one of the experiences that we had from the Swedish part is that it took a very long time to discuss the legal aspects of the study. The lawyers at the Karolinska Institute at the university and the hospitals had different views on different things. And the same was for the lawyers in Sweden and United Kingdom. And it also took a long time to write the agreements for exchanging data within Sweden and also between Sweden and United Kingdom. And this was something that I and my co-worker Malin Mattsson tried to understand and make decisions, although we were not lawyers. But still we did that, and it wasn't easy, it was hard. And also we write the ethical application, which took some time, as this was a complicated and complex study. And we also have to, it took time to search for fundings for buying, for example, arm crank, ergometer cycles and other devices to do the study. We learned a lot more in the study. It's, for instance, that it's important to have rheumatologists involved at an early stage for checking criteria, for doing some measurements, for example, measurement of blood structure and pattern in a microscope. And also we learned that we have to be prepared that some hospitals may withdraw. And one hospital actually did that in Sweden, unfortunately. And of course, we also think it's important to have regular meeting with the project investigators in that there will be no misunderstanding on how to perform the study and how to perform the measurement and exercises and so on. So can we make a collaboration in a multi-center exercise trial work? Yes, of course we can, but we have to be prepared that it takes a lot of time and effort, but in the end, it's definitely worth it. Karolinska Institutet, which is the university, and Karolinska University Hospital and Sunderby Hospital were involved. You can see the hospitals and the university on the slide. And we have many patients at Karolinska University Hospital, the slide in the photo in the middle. But as the first part of the study took such a long time, we had less time to include and exercise patients, unfortunately. So we only included 21 women with a mean age of 57 years. 17 of them had limited systemic sclerosis and 4 had diffuse. The disease duration was in average 11 years. And 12 of them were randomized to the exercise group and 9 to the control group. And patients in the control group were also offered the training after the study was finished, and 3 patients did that. So in total, we have 24 patients that have tried this exercise program developed by Alexandros and others. For most patients, the training went very well, and we heard this on the video as well. But for some patients, some exercise had to be adjusted. For example, the shoulder lateral raise, the second photo on the slide, because it hurt. Some patients got pain in their shoulder region, but that diminished after a while. Some patients also had to be examined by a cardiologist due to ECG abnormalities during the arm crank ergometer test, but they could later be included in the study. And as you see, most patients increase the load during exercise. And on the slide, there's a typical example. You see the exercises on the left, and you see the values at baseline and 3 months. And you see that the kilos has increased when you train with the dumbbells, and also when you look at the hand grip pressure, the numbers have increased at 3 months. And if we look at another patient, a rather healthy and strong patients, there are much more increase in the kilo when training with the dumbbells. And you can see in the chest press that there was a very huge increase. And that is due to that the patient was got so strong that she could exercise in a chest press training machine instead of dumbbells. So most patients increased, and this patient increased a lot. Here are some results from the Swedish part of the multi-center study then. The physical and aerobic capacity increased, and you can see on the photo on the left where the arm ergometric crank test is performing. And the biceps curl strength and the hand grip strength also increased significantly in the exercise group compared to the control. And this is in line with other studies that had evaluated high-intensity interval training in systemic sclerosis, such as Metropolis, of course, and DEFI and others. Here we can see the results of the physical and aerobic capacity. And if you look at maximal watt, if you look at maximal watt, the first row, you can see that the exercise group that is on the first row increased from 48 watt to 68 watts, and that is at 3 months significant, 0.01. It's underlined in the table. And if you look at VO2 maximal, the aerobic capacity liter per minute, you can see that the exercise group on the first row had increased from 1.02 to 1.14, and it was also significant. You can see that the numbers are underlined. And if you look at the last row, where you see the VO2 maximal in relation to body weight, milliliter kilo minute, you can see also that the exercise group increased that aerobic capacity. And it also was significant between the groups that you can see in the column right to the right. Let's see. And also I wanted to say that in an earlier interview study on patients with exercise in SSC, we found that some patients expressed it very important to exercise if you have lung engagements. So this is important results as we included patients with some lung manifestation in this sample. And here I have compared the Swedish result with comparison groups. And if you look at the maximal watt, you can see that the Swedish patient that had a mean age of 57 had lower baseline values than sedentary adults that had mean 57.3 in maximal watt compared to 48 to 42 in the Swedish material. And if you compare VO2 maximal liter per minute, you can also see that the Swedish patients had lower values than sedentary adults. I mean, we look at the last row with the aerobic capacity in comparison to the body weight. We can see that the Swedish patients were a little bit better on the group level than the sedentary adults, and a little bit worse than the patients with limited systemic sclerosis that you can see on the last row in this table. But this is in absolute values, and we haven't done any statistical analysis, and we haven't looked at the individual values, only the overall mean values and median values. If we look at the bicep curl test and the hand grip strength that was included as outcomes in this study, we can see also here that the bicep curl strength when using 2 kilo dumbbells increased in the exercise group significantly from 20 to 26 in the exercise group numbers. And also the hand grip strength was increased in the exercise group from 28 to 30.6, and that was significant, but not in the control group. And that was the same for the hand grip strength in the left arm. But there were no differences between the exercise and control group for the left hand in the hand grip. And increased muscle function is, of course, important as it can improve the activities of daily life. And if you compare the grip strength in comparison with reference values, we saw that the Swedish patient had comparable values compared to the general population. But as you can see, if you look at the minimal and maximal values, there were a wide variation. So there were those that were very weak in the grip strength and those that were very strong. And also the pain decreased significantly, and there was a tendency to increase the well-being in the exercise group. And if you look at the questionnaire SSC HIQ VSA pain 0.0 to 3 scores, you can see that the exercise group decreased from 0.54 to 0.21, and it was significant. It's underlying the row under, you can see that the control group is not, there's no change there. And if you go to the FACIT F well-being score on the last row, where the higher score is better well-being, you can see that the exercise group has increased their values and thereby and they have a tendency to significance to have an increased well-being. But it was not statistically significant in comparison to the control group. As you can see, the patient did not have so much pain, but there are individual variation in the mean max values. So some have almost no pain and some have rather high pain. And what did the patient themselves say? They answered some questions, and 3 patients said that they had pain or muscle soreness in connection with some of the exercise session. And 2 of these also mentioned that they could be tired after some exercise session, together with one more patient that also answered that. But most patients were very satisfied with the exercises. And here are some quotes. They thought it was a very good exercise program. And they thought that some thought that they increased the strength and range of motion, and they were less swollen and less stiff in my neck, and some have lost the weight and felt more energy, and they also felt emotionally much better, and it was good for body and soul. And there were no other negative consequences from the training program. And some of the involved researchers in Sweden wanted to investigate if the blood flow could be increased due to the training by measuring blood flow with a device called Endopath. I don't know if you've heard about it, but anyhow, well, unfortunately, we did not have any reliable data from these measurements because maybe due to the device, the computer, and maybe also due to the person who did the measurements. And according to Moreland 2012, it's essential to recognize that the part of the blood cells that is measured by the Endopath may differ from conventional techniques. At least we did a try. And in conclusion from the Swedish part of the study, we can say that the results indicate a high intensity interval training combined with resistance training in the upper extremity, increased physical and aerobic capacity and muscle function in patients with systemic sclerosis. Although some patients experience pain and muscle soreness and tiredness in connection with some exercise session, pain decreased at the group level. And there were no negative consequences of the training were found. And in order to draw definite conclusion, results from involved candidates, all involved candidates need to be analyzed. And here are some references where we have some abstracts on the Swedish rheumatology conferences where we have talked about the results from Sweden. And I would like to thank the patients, of course, that were included in the study, and my co-worker, Malin Mattsson, and the Karolinska Institutet and Karolinska University Hospital, Sunderby Hospital, and Alexanders and Marcus, of course, from Sheffield, Hallam University. And from those we got fundings, Forium, Swedish Rheumatism Association, and Region Norrbotten. Thank you. And
from my side, I will just mention how we started these studies back in 2015. I will go that back to see the aims that we had at that point and how we ended up to this European multi-center clinical trial. First of all, I will go very briefly to give you some simple factors that affect the blood vessel function. I know this picture is quite complicated for you, but the first thing that's happening within a blood vessel, other than the inflammation that Dr. Akil mentioned before, is that those natural factors that are able to open up the blood vessel, and we call them natural vasodilators, such as the nitric oxide, are decreased as a result of the pathology in systemic sclerosis. And those factors that are able to constrict and limit the blood flow, the vascular vasoconstrictors, as we say, they are increased in number. So this vascular imbalance creates a limitation in the blood flow. So yes, we've got this blood vessel vascular imbalance, which impedes the blood flow in the blood vessel. We do have, of course, due to this limitation of blood flow, lack of oxygen under the skin. We do have, over time, a narrowing of the blood vessel in the diameter, so it gets smaller and smaller. And we do have, within the the inner layer of the blood vessel, we call it endothelium. We do have injuries there, which are associated with the inflammation that we said before. So this pathology, the blood vessel pathology, will lead to Raynaud's phenomenon, might lead to open wounds, the so-called digital ulcers, the very right picture. And also because, if you can imagine, we've got blood vessels everywhere in our body, it will affect other organs such as the heart, the lungs, and the kidneys, with further complications. Quickly, we will say that 50% of people with systemic sclerosis develop severe low oxygen in the fingers. As we said, we've got lack of oxygen due to the limited blood flow. An approximate number of 11% might develop gangrene and amputation if the open wounds they start to develop an infection. The overall quality of life is decreased in systemic sclerosis. We've got a disease-related disability due to the complications. Systemic sclerosis affects roughly 8 per 100,000 people in the UK, of an average age of 57 years old. Of course, we've got a higher ratio in women compared to men, 5:1, and roughly the same ratio for limited systemic sclerosis compared to diffuse. And compared to any other rheumatic condition, systemic sclerosis has got the highest case-specific mortality. That's another reason that we should focus more on the treatment. So, having said in the slide about the pathology of blood vessel, and that we've got the natural vasodilators decreased and the vascular vasoconstrictors increased as a number, we need to see what exercise can do. So simply, before going to this slide, exercise can do exactly the opposite, increase the natural vasodilators through the triggering point is the hemodynamic stimulation as a result of exercise. To explain this quite simply, during exercise, we increase the heart rate and we increase also the blood volume that leaves the left side of the heart. This blood volume, increased blood volume, it goes through the blood vessels. As it is increased, it actually puts pressure on the blood vessel. This pressure, we call it in science shear stress, and this pressure is the action that it will release the natural vasodilator, the nitric oxide, first point, increase of production and bioavailability of nitric oxide. And thus, through this mechanism, we will have a better blood vessel function straight after one bout of exercise. And the more regular we perform it, the better it is, the more it will last. Also, through time, after 4 weeks, we start seeing alterations in the structure. So the blood vessel gets bigger and bigger and bigger. So other than the increased availability of the natural vasodilator, we do have alterations in the structure of the arteries that accommodate the blood flow more. So now it's the time that I will go back to 2015, where my aim was to assess the effects of exercise on the blood flow in the fingers. So how we can improve the blood flow. So the first thought, obviously, would be an exercise for the upper body, because the arm cranking, the upper body cycling would accommodate more blood flow in the fingers. However, that was just a hypothesis with no evidence, even from other populations, to tell me, okay, the upper body is better. So I had to test the lower body versus the upper body versus a control group. So we had 3 groups on this study to see which modality is better in order to succeed my aim. I did test cycling arm cranking. Both modalities were better than the control group. However, through statistical analysis, we did find that the arm cranking was slightly better to improve the blood flow, as this was assessed by a laser Doppler fluometry equipment and assessment. Before going to the second study, I would like to say that in this study, we also found that those that exercised, they did not develop any digital ulcers throughout the 3 and 6 months follow-up. However, in the control group, we had roughly 30% of participants that within 3 or 6 months developed digital ulcers. And of course, the quality of life for the exercise group was significantly better. So knowing that the arm cranking is better than the cycling and than the control group, I did continue to test the feasibility and effectiveness of a combined exercise protocol. This time we had both aerobic training and resistance training. So we added in study 2 resistance training. And we did assess the feasibility through questionnaires. We asked the participants and interviews how they felt. We did assess the adherence to the protocol, and the results were very, very positive and significant for the exercise group compared to the control group. Going to the point where we got the European grant, which was to assess the effects of exercise, of a combined exercise protocol, as we had it feasible and effective from the previous studies, on pain and fatigue in people with systemic sclerosis. That was a European multi-center clinical trial. We led from Sheffield Hallam University. That was a collaboration with Karolinska Institute, where Professor Karina was part of this, that she spoke earlier. Aristotelio, University of Thessaloniki in Greece, University of Naples, Luigi Vanvitelli in Italy, Sheffield Hallam University, Leiden University from the Netherlands, and the University of Copenhagen in Denmark. Forum was the funder of this project. The project started in 2021 and completed in 2024. We're still doing some data analysis. So before the exercise intervention, which was for 12 weeks, and I will give more details, we did some baseline assessments, which consisted of questionnaires about pain, fatigue, depression, and quality of life. So that was the questionnaires that we performed. We performed a blood vessel assessment, which we call it an L-fold videocapillaroscopy, a cardiorespiratory fitness assessment, which we call it in scientific terms peak oxygen uptake test, and 2 musculoskeletal strength and endurance tests, the hand grip strength and the biceps curl tests. We All over Europe, we randomly allocated the participants in two groups, the exercise and the control group. The overall program for the exercise was 12 weeks, twice per week, of a combined exercise session, supervised by a trainer always. And then we performed all these assessments above at 3 and 6 months to test the differences between groups and after the exercise. This is a very short video of how we performed the peak oxygen uptake, the cardiorespiratory fitness test. So this is the screen where we can get the breathing variables, among them the oxygen uptake. This is the electrical signs of the heart and heart rate during exercise. And you cannot see, but we do have a mouthpiece where we collect the oxygen. And this is the gold standard assessment for cardiorespiratory fitness, the amount of oxygen that an individual can get and consume at the same time. This cranking test roughly had a duration of 6 to 8 minutes. It is a progressive load test, and we actually assess the peak oxygen uptake, but also the peak power output. So how many watts each individual can do at the end of the test. So by knowing from the previous test that you just saw, by knowing the peak power output, so the peak watts for each individual, then we are able to individualize the training and prescribe a high intensity individualized interval training. So in this figure, you can see that the participant was exercising for 30 seconds on the 100% of peak power output and 30 seconds either passive, doing nothing, or very low active with no load arm cranking. The overall time of the aerobic training was 30 minutes. So you can imagine the actual time of HIIT was 15 minutes. Going to the resistance training, so we had 30 minutes of aerobic, and roughly this protocol that you can see here, it's roughly 15 minutes of time. We performed 3 cycles of 10 repetitions maximum based on individual responses, the maximum weight. So we did perform the chest press with dumbbells from a 30% incline bench. We did the arms lateral raise with dumbbells in a seated position, biceps curl with dumbbells, triceps extension on the pulley from a standing position, and then we used either the hand grip dynamometer or tennis balls to perform the 10 maximum repetitions for the hand strength. So going to the first table and the results, first of all, I will say that we're going to see three tables, I think. All of the results that I have put here are statistically significant for the exercise group compared to the control group. Because we don't have time, I haven't put those that they were not significant. So whatever we see here, it's like statistically significant for the exercise group. Starting with the first one is the body composition. You can see that the exercise group developed significantly better the body fat mass percentage compared to the control group. And this is the results at 3 months after the exercise intervention. And then from the other questions, I will just mention a few just to give you an idea. So if we go to REACH A, the question here that we ask, and we found out that exercise group is better, it mentions, are you able to reach and get down a 2.5 kilos object, such as a bag of sugar, from just over your head? So the answer was better for the exercise group. For the activities B and C, the questions were, are you able to get in and out of a car? And the other question, are you able to do chores such as vacuum or yard work? And to finish with eat, are you able to cut your meat? They are basic activities, but as you can imagine, cutting meat or the walking activity, climb up 5 stairs, these are activities that we need strength and endurance to perform them. Going to the second. In the next table, again, we can see statistically significant differences between the exercise group and the control group in social well-being and emotional well-being and functional well-being questions. There are a lot of questions within these 3 sections, and the FACIT-F refers to the overall fatigue levels. On these questions, the higher the score, the better. And going towards the questionnaire for quality of life, which is a systemic sclerosis specific questionnaire, the lower the number, as well as in the depression scale questionnaire, the lower the number, the better the score. So fatigue, systemic sclerosis, quality of life, and depression scale was significantly better for the exercise group. Finally, what we would expect in terms of fitness as well, the hand grip, biceps curl test, as well as the cardiorespiratory fitness test that we performed, and the strength, the peak watch, and the strength of the heart rate peak were significantly better for the exercise group. To conclude, our exercise program can improve disease-specific quality of life. It can also improve systemic sclerosis symptoms. It can reduce pain and fatigue caused by systemic sclerosis, as this was questionnaire specific to pain and fatigue for systemic sclerosis. And it can also improve fitness, reduce body fat, and improve muscular strength and endurance. We need to mention that these were the results after a 3 months exercise intervention. We have to analyze and see if those results could be maintained for the 6 months. But a very important note is that at the point where we're going to stop exercising, the deconditioning, the so-called deconditioning that we call, will come quite fast. So any benefits of exercise will not be maintained forever if we do not keep on exercising. We also have to mention that the exercise program indicates that at least 2 sessions per week can develop some improvements. So the answer is the more, the better. If we answer ourselves how much is better.
Thank you very much.